Okay. Hello, everyone. My name is Razia. I'm back with another new topic that we can be tested oftentimes. And more than anything being tested, we only need some um, important things, right? So that we remember. And so let's get right into it. It's going to be exciting. Stick throughout the end of the video. We will discuss every A's and B's and every situations. Okay. So let's jump right into it. My topic for today is gonna be peripheral arterial disease. Peripheral arterial disease. So what do we know about it? Some background history in terms of symptoms. Six P's: pain, pallor, pulselessness, poikilothermia, and so on. There are six P's. So you might want to remember those six P's. Okay. The next thing is to note the risk factors. What are the risk factors? First one is hypertension. As the name suggests, it is vascular disease. Another vascular disease is diabetes, smoking, age. Of course, it happens in older people. There is a reason being calcified vessels. The same mechanism resonates with diabetes as well, especially late onset. We don't want calcified vessels, but then we can do much because it is irreversible. Lastly, cholesterol levels. LDL cholesterol is the bad cholesterol, and so we might want it to be less than 100. With this basic background, it is easier to approach the orders. So, what are the orders that we can do in this case? Ankle brachial index. As we said, hypertension, if it is over 160. The patient needs to be on antihypertensives. Luckily, if the patient is having diabetes, we might end up doing the most important drug that could be hit for two, and that is lisinopril. So each risk factor is like having a link with each other, as you can see. For example, HbA1c is high in this patient. There is definitely the need for first line agent, which is most times metformin. Also, with metformin, the outcomes are good. Apart from this, there is one extra step for diabetes. We can remember as diabetes being the major risk factor for PAD, and that extra step is urine microalbumin. Pardon my skill of writing. I just hope it makes sense to you. So, there is this test that will always be important. Okay. It's 24-hour urinary microalbumin. Reason being, microalbuminuria accounting for early onset glomerular disease. And then if it is 3 plus, it is late onset, which can again contribute to calcinosis. So these are important investigations. If you miss out on HbA1c, or let's say any other antihypertensives, there is always a chance of not having your case end in a right situation. The only outcome for CCS is to end on a good note. And so it is very important to approach your CCS cases in a stepwise manner. So, lot of times I have experienced myself personally, and also I have seen many people miss out on the big things. Now, apart from CBC, BMP, checking the lipid levels, blood pressure monitor, urine analysis, and so on, there is basic aspects to know, one of which is angiogram. This is a big time question. So there can be situation where you can get confused whether to go ahead with this investigation or not. Since every case will not have black and white situation. You may want to taper in your investigations a little bit according to what you're presented on your exam day. So, going back to this question whether we need angiogram or not. For this, we may want to firstly note what kind of PAD we are looking at. So this is intermittent, meaning pain during walking, and it is manageable. Okay. So if it is manageable, I just want to ask you one question here at this point. Would you go ahead and do angiogram if it's manageable? Let's say you got a patient on the exam days reporting to you that he has pain, and then he also states he has pain here and there during rest, but he loves enjoying a walk with his wife. So, in this typical case, will you go and do angiogram? Think about it. I mean, the basic thing they want you to note is for intermittent, you don't need to do angiogram. If you do so, you may lose your points. As simple as that. Why? Because it is invasive and it is contrast agent having other side effects, because of which it is a big no on CCS. You can go ahead and do ultrasound of lower extremities. That is fine. But then angiogram is definitely a big no. For intermittent cases, all we are doing is graded exercises, smoking cessation, aspirin or clopidogrel, dual antiplatelet therapy, and medication compliance and lifestyle changes. All this may be sufficient enough for intermittent pain. Okay. Um, so this is about PAD. If you have any other doubts, feel free to leave in your comments. And that's all for now. Thank you so much.